It's a great honor to be here today. You just said it one slide with Lemon Mint, DHI, and IDF. And this, I must say, this is a very cool slide because it shows the potential of collaboration. And there are most for Lemon Mint written, think, act, health. And I would say this is exactly what we should do today. Discuss, think about what can Scotland learn from the world and what the world can learn from Scotland and what we generate by learning from each other as a new level, a new threshold of thinking and acting in diabetes. And then we should go out and start not tomorrow, today, already acting on it. And finally, we should translate this into better health. One potential they see here is in the rule. Because we had the discussion just now, why is Scotland so good? And I would say it's a small country, and all the people who are influential, who are leaders in diabetes care, who are leaders in digitalization for health are here in the room. And you don't have this opportunity in any other country. You can have it in Saudi Arabia and talking to the Minister of Health, and he decides. I had a meeting with the President of Mauritius. Diabetes is on presidential desk in Mauritius. And this is very easy because you discuss with the President of Mauritius, are sensors paid or not paid for people living with type 2 diabetes or type 1 diabetes without or with insulin? So this is a big opportunity, but then you have examples like Germany with more than 100 concert shows company. So this diversity in the sectors or silos of healthcare is a big barrier. And all of the people who can discuss this are here in the room. This is big, big potential. 2 weeks ago, I was in Geneva at the General Assembly of the WHO. And it was very cool as well to walk over the street, and you need 2 ministers of health by walking over the street. But it was very political, and there was a lot of visionary ideas and discussing this industry, this our industry. But it's not the think, act, health as it is in the wood there. About myself, everything was said. Being the president of the International Diabetes Federation is very cool, and I have learned about diabetes in the last honor how it was than in the 21 years before. By going to the countries, by seeing how they do diabetes care. And I think we have to act to make a change. The big thing is we have to cooperate and influence ourselves with the ideas from others. I'm very sure that any problem in diabetes care, and if I'm talking, it's always diabetes, diabetes, diabetes. Any problem in diabetes care, someone will be able to solve, but we don't know through it. And this is the barrier. This is the problem. And this is also Scotland. Everyone knows, in Scotland they do something good. And what exactly is the essence? Why Scotland is good is often not known. To show you some snapshots, that is the biggest diabetes clinic in Madagascar. And this is the way how diabetes care is done in Madagascar. This is the storage, this fridge, the storage of all the insulin for all people living with diabetes in Madagascar. 70% of this insulin comes from USAID. Came from USAID until the end of May this year. So this was 3 days ago. And seeing this and getting the experience, this is the president of Mauritius. This is an influencer. This is a source of information, source of ideas. You cannot pay for it. Yeah, this is the unbelievable to see this. This is an example of a diabetic food clinic. There are more than 100 physicians are employed only for diabetic foods in Pakistan. So we don't know from this. Yeah, you have to go there to see it. And there are a lot of passionate diabetes leaders all over the world. And I think this is something that we can build a lot of trust and a lot of confidence into it. The passion, the enthusiasm, the energy to build a global community of actors in diabetes care is there. But sometimes we are missing the tool. If I read Digital Healthcare Innovation Center, developing the tools, maybe here in Scotland, which then later on gets implemented somewhere in the world, could be a way forward. But let's dive into it. Why is diabetes a problem? WHO says 830 million people living with diabetes. IDF says 589 million people living with diabetes. You might say, that the big organization doesn't know what they are talking about with the two different numbers. But both are right, because they use different diagnostic criteria. Also some things what we have to address. But the number of people is growing. They are not growing in Europe. They are not growing in America. They are growing in Southeast Asia a little bit still. But the big growth will be Africa in the next 10 years with a tripling of insulin. But the workforce will not fall. So we have the same number of colleagues, Same number of community health nurses addressing this, and this is influencing the quality of delivery of care. The reality, as I already said, WHO is talking about 830 million people living with diabetes, and where are they? They are low and very low-income countries. They are not in Europe. 87% of people living with diabetes come from 4 countries. It's China, India, Pakistan, Bangladesh. So what are we doing in these countries? I clearly say if IDF wants to have an impact in the global quality of diabetes care, it has to have an impact on this country. So talking about the good experiences here, but translating them into the environment there, this is the challenge we have to address. Is the number of people with diabetes a problem? I would actually say no, because we know the number and we can develop strategies, but the morbidity and mortality, and mainly the morbidity of those people is a problem. Because if you're in India and you are a woman and you have a BMI of 24 and you are 28 years of age and you develop diabetes with a period of 6 months only of pre-diabetes, you have a lot of years with insulin resistance, liver fat, NAFLD, and this can be translated into higher morbidity. So you die 17 years earlier by the data today. And this is something the healthcare systems are not prepared for. For diagnosing diabetes, I think this is something that could be managed, but the morbidity, no. These are the data of the International Diabetes Federation. The difference is that IDF relies mainly on OGTT data, WHO mainly on fasting glucose and A1C data. But we also could say it makes no sense on a global scale that we have 4 different ways to diagnose diabetes. And now the 1-hour notice is coming up. So then we have 5 ways of diagnosing diabetes. But 2 days ago, we have founded a commission from the International Diabetes Federation to harmonize the standards of diagnosing diabetes, WHO, ADA, ASD, IDF, and World Diabetes Foundation together. So this will be a big step on global harmonization. But then we have WHO. Again, 30% less funding due to our big partner or big friend in the United States, but they have interesting goals. 80, 60, 100. 100%, the last one, of people living with diabetes or living with type 1 diabetes should have access to affordable insulin. We are far, far, far away from this. If we have big European pharma company who have a name which is very similar to the name of a building here, if they withdraw 5 cheap insulins from the global market, the cheap insulins will have had a big impact in India and Bangladesh. And they come and say, we understood this signal, we withdraw them from the market and translate the potential into the production of GLP-1 analogs. This makes diabetes care in India 22 times more expensive than in the past. And this is not an opportunity, and this is something that these companies do not take their social responsibility. But again, the situation is a challenge, and there are new determinants. You might say this is the map of increase in prevalence of diabetes in the future. It is not. This is the relevance of air pollution in conjunction with type 2 diabetes. And if we would go out of the building and we stand behind which German diesel car for 5 minutes behind the diesel car and we take some deep breaths, you find medium-sized particles out of the diesel engine 2 weeks later in your insulin-producing beta cell. It's fascinating, horrible. We don't know what it means for diabetes. If you do the cell culture in carcinogen situation by 30%. But this is a forgotten determinant of the development of diabetes. Again, we could say there are less medium-sized particles by the rain in Glasgow in the air, but if you are Delhi or in Mumbai, it's a totally different story. And the government has said there is no car with an air Verbrennermaschinen. I don't know the English word. Electric machine. So if you burn petrol, yes, it's not flowed in Mumbai and Delhi anymore because of this fact. But what is, if you ask me, and people come and say, you as president of IDF, what is the main determinant of the diabetes development? And then you think about 200 different determinants of diabetes. So what is the main determinant? And to make it easy, it's this. It's fried carbs. If you fry carbs at a temperature of above 109.7 degrees, then you build bonds between glucose and fat. And the body cannot break them down, and they are getting stored in the liver. So this is the way how our diet, how our cheap diet makes the very fast progression of development of diabetes. due to accumulation of fatty liver. So this is MAFID, NAFID, NASH, and MASH. And I think this is something we have to address in the future if we really want to improve the health of our citizens. Is it relevant here? I would say yes, but there is a very, very, very relevant is on the street markets in India, in Bangladesh, in Pakistan, because this is the food you can get there. It's lekker, but it's not good. There's a clear impact. Half of the people dying every year die with diabetes. So they also die with obesity. So is obesity or diabetes the main problem? Is the heart a problem? I don't want to have the battle who has a bigger health problem. It's a big problem for morbidity and mortality of our patients. But more than 60% of them don't get good care. So this is also something we have to address. And mainly it's in low and very low income countries. There are big problems also here in Europe, but mainly in other countries. The healthcare systems are challenged so much that we don't have time anymore for our patient. We often lack guidelines. We often lack the ability that patient gets more engaged and involved. We have fragmented level of care. And we have also big problems in terms of access to care. And this is something that I'm very, very sure that digitalization and later on also AI can make a disruptive difference to it. What is the role of digital? And digital, in my eyes, is already the old-fashioned way of technology. You can have a different way of access. Makes it a different, of course, if you have access, if you are interested in it, it's good. It's an improved communication and you can deliver personalized intervention. Being in the pocket of the patient can make a difference if you're only talking about very simple digital intervention. If you talk about diabetes, self-monitored is a big asset for people living with diabetes. Digital can help to improve this, but also to translate this into a remote fashion. So they don't have to go to the physician, but the data are accessible. This is maybe mild, but for some people it's a big impact. Education can be targeted onto the level of glucose. So imagine if you have a sensor and if you compare the sensor reading to a swarm of other patients using a similar sensor, you can exactly track what the patient is doing. You actually, by the sensor reading, you can see what is the patient eating. And you can use this to target educational motifs to each patient. And this is personalized, individualized care. And I hope that this can be translated to improved outcome, better self-management. And at the end, also mental well-being is something what we often forget for a patient. Think about sugar and sugar and sugar, but there's also heart and the soul of our patient. And often this is much more important for the patient than the sugar. But digital tools, glucose monitors, telehealth, mobile apps, it's cool, but this is not the future. The future is going far, far beyond this. But even here, you have challenges. If you are talking about Congo, not everyone has a smartphone, but in many very low, it had a smartphone. So it's on one side a barrier, on the other side it's an opportunity. So how to use it? How to deal with data privacy problems? We had a discussion just here in Europe. We are very good at regulation, and we could say regulation improves patient safety. And I think this is true. But we also could say regulation might break innovation. If you're in India, there's no rule, there's no legislation how to use software in health. So everyone can do whatever he wants. It's a big driver for innovation. Also for bad innovation, but the innovation is there. So what is better? Is it our system? Is Southeast Asia? And how to integrate both into each other? But I'm scientist, I'm physician. And gray, here you see how our drugs lower A1C, green, how lifestyle is doing, blue, how digital tools are lowering A1C, old, medium, old, and young digital tools. What are young digital tools? Are smartphone-based apps. And how can an app on a smartphone lower A1C? The hardcore scientists would say, Peter, you might be president, but it's crazy. How can an app lower A1C? It's not a drug. And we are in the pocket of our patient. We never have been so close to our patient than being in the pocket. This is brilliant. Every one of us is taking 1,800 decisions a day. 450 are related to our lifestyle. Now imagine in the right moment is the right education motif, with the right motivation message, to influence only 10 out of the 450 decisions, but do this over the period of 1 year. It's 10 kilograms of weight reduction. And this is the power of digitalization. There are examples in Germany, licensed and reimbursed apps for diabetes education. Then another one using AI, that the people are making photo of what they are eating. It doesn't matter, it can be Asian food, and it's qualified and quantified, but the patient's not getting blamed for what he's eating. The information is used to help him to choose the next eat. Very cool. It's about 1.2% A1C reduction within 3 months. So it's a very good development. Also using the sensor for nutritional education for the people living with diabetes. Or here in Swedish example, using also the sensor and automatically, this is the example that I just mentioned, comparing the sensor reading with a swab of more than 1,000 patients in Sweden. And by this, exactly knowing by the volatility of the glucose excursion, what the patient is doing. And this app is diabetology out of the pocket of the patient, because the app says today at 6:35 you inject 22 units of long-acting insulin. Medical product class 3. And every one of the physicians would say, no, we don't want this because it steals our work. Think about Rwanda, 380,000 people living with diabetes, one endocrinologist, and a digital infrastructure vision better than Europe. So these are opportunities for low and also very low income countries in the world. And it's basically AI used to analyze the shape of the glucose curve and then translate this into clear medical treatment by recommendation. I think very cool development. And the International Diabetes Federation is very keen to push this forward, because this immediately will improve health for people having access to these tools. But there are also other developments. This is MATU. This is development of 400, 500 physicians in India called Doctors AI. And they developed an AI-based agent you can use via WhatsApp to talk with your glucose sensor or with your glucometer. And so you can use WhatsApp, or everyone in the world is using, and talk to your sensor and ask, yeah, what was it yesterday with this spike? And Matu gives you a recommendation what you might change today, and then see the change of the reading for tomorrow. So very simple, very easy, no opportunity to get it licensed in Europe, but it's used in India. And physicians say this helps them, the patient will have a digital literacy and digital adherence, that they have for self-management use or triggered by Matu, and they don't come to the office, but they pay for it. So it's very liberal. It's you pay a month less than a movie ticket in India. So it's a cheap development. It was evaluated, and social indicators, medical indicators, evidence-based glucose indicators, it's a good outcome. And comparing that, in this study, they also compared it to a network of physicians, and Matu was better than the combined brain of all the physicians, but talking to a single patient. This is something that we should think in the future. Who is better? Is it our medical brain, or is it the brain of AI? Is AI becoming a physician? It's an interesting question. We tested this, and AI, Matu, was doing the medical exam in India within 2 hours and passed. So something to think about. So I think in AI, there is a lot what we have to think about in the future, because AI might help us to address the gaps we have in diabetes care and diabetes prevention, underutilization of programs. We have excellent programs, but they often are not used, or the people don't know about. Screening gaps, the personalization of programs, and go on and on and on. And using AI and using the approaches of digital AI-driven digital solutions might solve some of the gaps. I will not say that AI will solve everything, because if you are talking about generative AI, using all the sources which are available in the internet to learn, and Google telling me that 85% of the medical sources in the internet are wrong. So we could say AI is also learning from the wrong sources, which could be a danger, which could be a risk for our patient. The alternative approach is Doctors AI, where 500 physicians have learned or triggered the outcome or the learnings of AI. And maybe this is a way to go forward. But if you are talking about AI, everyone has a different impression. And They are good in evidence-based diabetology. If you go to all the congresses, you find new studies, cardiovascular outcome studies, where they spend 200 million euro for a certain drug and look what is the 2% or 20% change in cardiovascular risk. So we are very good in evidence-based diabetology. We are very bad in data-driven diabetology, and there are millions of data available. We have challenges how to bring the data together. We have challenges in terms of data security. Can we use this data? But AI is a bridge between this. AI can make use of millions of gigabytes or terabytes of data, and to translate this maybe in the future into evidence-based diabetology. And this will change the way how we do science. This will change the way how we do studies. And if we are going ahead in diabetes management, there are a lot of applications, easy, accessible, already existing applications in education, in diabetic foot care, retinopathy screening. Retinopathy screening in India is done by AI. There are 2, 3, maybe 10 ophthalmologists being the hookup if AI doesn't know what to do. But the screening is done with a camera on a smartphone in the rural villages in India. This is cool. This improves care, even if it might not be perfect yet, but it's improving the quality of care for people living with diabetes. So I think the future in AI is not only improving the way how we deliver care or health, it's much more to identify people with having a risk, having a certain behavior, having a certain mental risk much earlier than we do today. Because our classical health state, we wait until the patient has a symptom or a diagnosis, then we do the diagnosis, start treating. In diabetes, we know that it's 20-25 years before the patients already accumulated risk factors. So the accuracy of prediction of risk or prediction of the disease, this is the power of AI. But our healthcare system doesn't follow, because our healthcare system is driven by having a diagnosis and prescribing treatment. So having AI identifying risk, then it falls in a big hole because the healthcare system cannot use this. And this is something else what we have to work on to change. There are good data to predict risk by using sources. And from this group, also a study is coming from that the best accuracy in diagnosing the risk of getting a hyperglycemia is analyzing the shopping behavior, the online shopping behavior. And this is cool, actually. Now, if you know that someone will get a hyperglycemia 3 months before he gets a hyperglycemia, he could start doing prevention. Now, we never have been able to know this. What does the healthcare system say? Oh no, we don't want to have digital diagnosis in our guideline. Why not? If we know that someone will get a risk, we are ethically obliged to do something. Changing the environment, giving opportunity. It must not be treatment, but it could be other approaches. I also think that in education, AI will be a booster, because every one of us thinks we know everything about diabetes care. It's not true. Every one of us has its gaps. We sometimes don't know what are our gaps. Sometimes we know. But using AI to helping us to find our own weakness, our own barriers, our own gaps in knowledge, and closing them could be a very fast way forward. And the next thing is also using it for interventions. This is what I meant, coaching and education out of the pocket of the patient. Finally, every one of us dreams about AID systems and closed loop systems. And they are very, very close to it. And I actually think we are there already. But it's not what we thought 30 years ago, that we have a closed loop system, what we implant to the patient. I think AI was the missing link. And these are the elevations of how to use AID systems today. And the missing link, this AI, will make the release of the insulin triggered on behavior, on personal needs, on glucose level, on insulin resistance, on obesity level for the patient in every minute during the day. So 1,440 times a day. And maybe this is actually better than the humo beta cell dissection. I don't think that it's better. The beta cell is the coolest thing what we can have. Finally, we have to think how to implement this.
And also there are challenges. Yeah? How to integrate it into our workflow. I gave many examples where the physician says, no, we don't want, because it's stealing something from us. Many physicians doesn't want. Yeah? We are not working in an environment like Rwanda. Yeah? We are an environment where we often have too many physicians for the patients. What is with interoperability? Yeah? I gave an example in the morning that we have a hospital in my city in Dresden, and one hospital is measuring blood pressure and coding it in the electronic health record. And our hospital is also doing it. But these two records cannot talk to each other because the blood pressure in one hospital may be seen as blood sugar in the other hospital because of the different coding of the things. What is with financial aspects, how to validate this, how to validate AI output across ethnic groups and across different social groups will be a challenge in the future. Also something IDF is very active in, focusing on the need of different social groups, different ethnic groups, different religious groups, that the output of AI is including this and balancing this. And they are getting better and better, and there are more and more regulations including this. Privacy and governance is something we are very, very big, I would say, today in the use of AI in diabetes care. But there is more and more coming. There are tons of laws already worldwide addressing the use of AI in health and diabetes care. The European Diabetes Forum was one of the frontiers to have a kind of statement how the use of AI for healthcare professionals, for studies, for clinical decision systems, for data standards and clinical capture of the data should be done. But the scalability should be very low. If we don't have an impact there, we failed our missions and we failed our vision in implanting technology into improved care. So let's start thinking about how to train ourselves, healthcare professionals in the medical schools in the use of AI. The IDS School of Diabetes has more than 108,000 people who have already looked into the training programs in digitalization and AI. This could be a way, but at the end, it has to be in the curricula. If we are training more workforce, there are. I'm very sure that AI will reshape how we do diabetes care. That we have to take clinicians onto the hands to do this. We have to validate this. I think AI-used care will be better than our brains, but still we have to validate the outcome. We have to get policymakers into the boat, not to fear the AI. And I think this can be precision medicine also in very low and low income countries worldwide. Finally, there are tons of digital biomarkers. So think about digital markers on your phone. Yeah, if we say we go away from AI and we go away from wet lab, and we use digital markers, we give it back to the patient and we do prevention with this, everyone is agreed. If we do prevention, we also can do education. Still, maybe everyone would be agree. Maybe at least here in Scotland, not in Germany. If we do education, why not also doing care? Yeah, AI, I think in the future can be better than care. And this, for me, is the future of AI-based diabetes care. Do we? As president of IDF, I have installed a group, AI in Diabetes, is led by Amit Dey from India, and they will develop a guideline for the use of AI in diabetes care. Will come out in about 9 months from now onwards. And if you ask why we need IDF, I think we need a powerful voice for the need of people living with diabetes. Because there's a long, long way to go. And I truly believe that everyone with diabetes has the same right to get the same access and availability of diabetes care, not only for care, also for prevention. And as a president of IDF, I have only 3 goals. One is to be in the brain of every politician, to be in the pocket of every diabetes patient, and to be in the heart of every healthcare professional. And how do we want to reach this? The Global Diabetes Index. Once a year, we will measure the perception of quality of diabetes care in each country in the world. 4 weeks before World Diabetes Day, we will feed it back to for free to anyone to use it. And it might encourage the health minister of health in one country to do something because the neighboring country scores 5% better. Secondly, diabetes education using AI in the pocket of the patient with free access for the diabetes patient in Congo well, not enough money to go to the physician or the pharmacist, but might have a smartphone. Still, this is a barrier, but we will reach many more than we reach today. And we can learn from a good experience here from Scotland also to translate this worldwide into care. And IDF has launched a fellowship program. So building a coalition and a community of passionate colleagues worldwide as fellows of IDF to translate evidence-based but also perceived good care in the use of AI into improved care. There are many faces of people living with diabetes. They deserve a better life, and let's work together to put a smile on these faces of people living with diabetes. Social media is becoming more and more important. This QR code is a WhatsApp channel from me as president of IVF, where I inform about all these activities. Maybe the photo from you just made will be there soon. Let's work with our different ideas, our passion, our intuition together to finally help our patient to walk away from diabetes. Thank you very much.